And a couple of messages I'd just like to mention before I forget, because they're very important to mention to anyone, any talk about ovarian cancer. First of all, is all women with ovarian cancer should be tested for BRCA1 and 2, maybe more genes, but at least BRCA1 and 2 germline or inherited mutations. Why? So this nowadays, as you might have heard about new FDA approvals for new therapies, PARP inhibitors, nowadays, this has many implications. First of all, it usually does not have insurance implications. So that was a big concern for people 10 to 20 years ago when we first started doing this. We have the GINA legislation, which is the Genetic Information Non-Discrimination Act, which means you can't or you're not supposed to be discriminated against on an insurance basis because of a germline genetic mutation. And that's pretty true. I don't think there's anyone being discriminated against as far as health insurance goes because of a familial mutation. It does not necessarily protect you from luxury insurance, which would be life insurance, possibly disability insurance. I always like to say that it doesn't really matter, because even before we knew about any of these mutations, the insurance companies are smart, but they're not that smart. So on the one hand, they don't care too much about these things because they want their money, that you're going to pay them for their insurance. On the other hand, they typically ask you about your family history because they're also not dumb. And so they would say, does anyone in your family have breast or ovarian cancer? And of course, if you lie on the insurance forms and then you want to make a claim, they're going to go back and say you lied on your insurance forms, your policy is null and void. So if they say, does anyone in your family have ovarian cancer? You say, yes, my mom and my sister have ovarian cancer. They know you're at high risk for ovarian cancer, whether or not they know you have a BRCA1 mutation. So I don't really think there's a lot of even luxury insurance discrimination. I don't know that as a fact. I've never heard of it. So genetic testing should not, insurance reasons, I don't really think should be a concern for genetic testing, and there's so many benefits that I don't think a lot of people are worried about this anymore as they were 10 to 20 years ago. It's simple, it's a blood test. It doesn't even have to be a blood test. If you're godly afraid of needles, it could be a saliva sample. It's very easy. We're doing that now at some of our research studies across the country. I will mention something before I forget. There's a new study that's not open in New York State for some New York State regulatory reasons, but there's a new study called the Magenta Study. It's part of a consortium. I don't have a slide about this, so I'll just mention it now before I forget. It's part of a consortium of the Stand Up to Cancer Ovarian Dream Team. It's a consortium of centers led by MD Anderson, Dana-Farber, Mayo Clinic, University of Chicago, University of Washington, and NYU. The Magenta Study is a risk population genetic testing study. Basically, if you go to magenta.mdanderson.org or just search for Magenta ovarian cancer, it'll come up. And anyone in the country, except for New York State right now for a regulatory glitch that we're working on, but anyone in the country can go on, answer about 5 or 10 questions. We'll ask you, are you female? What's your age? Have you had ovarian cancer, which would exclude you? And some other questions. And if you're basically around, I think 30 to 50 years old, but it could be, there might not be an age limit, but basically if you are at somewhat increased risk for ovarian cancer based on the family history or anything else, because there's lots of inclusion criteria, you can have virtual genetic counseling. So through the actual website, Magenta, you can sign on to the research protocol. And the whole purpose of the protocol is, can we get genetic testing out to the country in places where they may not have, 6 million doctors in New York City. So some middle part of the country where it's not easy to find a doctor, a G1 oncologist, or a genetic counselor. Can you go online? Can you, for now, consent to the research protocol? And then you'll be sent a kit from Color Genomics, which is the company that we're working with. They will take a saliva sample, they will test it for you, and the randomization on the study is, do you get information on the website, do you get information from a phone call, or do you get information through a video chat with a genetic counselor, and then they ask you to answer some questions on how does it, what are your thoughts about that. But anyone in the country who wants genetic testing, it's actually free. Magenta is the study for that. So saliva or blood. Now the biggest reason to have genetic testing if someone has ovarian cancer is to then advise family members as to whether there are increased risks. Because as I'll talk about, there are many things we can do to lower the risk of someone who may be at high risk for ovarian cancer. That can include surgery, which some people may feel is very aggressive and some people may feel is routine, particularly if you're the surgeon. And it may involve hormonal therapy, birth control pills, other things that are much less serious than surgery, and also depending on how old someone is, maybe more or less appropriate. So the biggest reason is if we can find families that carry BRCA mutations, we can prevent ovarian cancer. We know we can do this. We can either prevent it or reduce the risk. And when I say prevent, I really mean reduce the risk back to the population of 1% over a lifetime, which is pretty low. We can't do better than that. The other thing we're working on now is something called cascade testing, and it's just related to this. So we're quite good here and at many major centers of testing everyone who has ovarian cancer. We're much less good at testing everyone's mothers, sisters, and daughters, because that's again where this comes in. So that's called cascade testing, because you find someone with cancer who has a mutation and you cascade the process to other people who may be at risk. And as I also may forget to mention, if someone has a mutation, all of their first degree relatives on the female side, that would be mothers, sisters, and daughters, have a 50% chance of having that mutation. So it's not necessarily terrible if you have a mutation, because if a mother has a mutation, because the daughter would have 50% chance, which is why you want to have genetic testing. Finally, therapy. So nowadays we actually have specific therapies called PARP inhibitors that work quite well and are FDA approved in some situations only for women who have ovarian cancer and have a BRCA1 or 2 mutation. And so that's the other reason why we want to test everyone for BRCA1 and 2 mutations. Finally, the other point I like to make is that if someone has ovarian cancer, all of our professional organizations suggest that the best treatment is when it's provided by a gynecologic oncologist, who's someone specially trained in treating cancers of the female genital tract, mostly ovarian, endometrial, cervical, and a few other cancers. And when people with cancer are treated by a gynecologic oncologist, outcomes such as survival and lower complications and better surgical outcomes are apparent. And so if you know anyone who has a gynecologic cancer, please ask them to see a gynecologic oncologist. When I started in 1995 to 99, there were about 650 G1 oncologists. Now I think there's about 12 or 1,300 in the country, because we're training a lot of people. There's more than we need in New York City, and there's less than we need in the middle of the country, and that's true, I think, for many medical specialties, and I don't have a solution for that right now. So moving on to a little more about the disease itself and prevention and screening. Another very important take-home point is that ovarian cancer is not one disease. It's many different diseases that come from many different places. We'll talk about the most aggressive type of ovarian cancer called high-grade serous ovarian cancer, where many cases begin at the end of the fallopian tube. The second and third most common types are endometrioid and clear cell ovarian cancer, and we also have mucinous ovarian cancers. These cancers are completely different from each other. They have different genetic mutations, they look different under the microscope, and the cell of origin, where the first cell that went awry, the first cell that went from normal to precancer to cancer, where that cell came from is completely different. So as I'll explain to you tonight, high-grade serous ovarian cancer, which again is the most aggressive form, we think frequently originates at the end of the fallopian tube. And endometrioid and clear cell cancers are called endometriosis-associated ovarian cancers, meaning many of them grow out of endometriosis. Endometriosis is when the lining of the uterus, the endometrium, which normally sheds every month during the menstrual cycle, when some of those cells go out the end of the fallopian tube through something called retrograde menstruation, which just happens because the fallopian tube and the uterus and the vagina and the cervix are all connected to the inside of the abdomen and to the outside world. And the flow can go either way, but usually the path of least resistance is normally to the outside world, but it can also go backwards or retrograde into the pelvis, and those cells can implant and develop a blood supply called endometriosis that can lead to infertility. That does increase the risk of these types of cancers about twofold, and that's nothing that we do anything about. We don't get too concerned about that, because twofold is not what most people would consider a very increased risk, nor is there an intervention that we can mitigate that small increased risk. And then these cells can sometimes turn into ovarian and clear cell endometrioid cancers. And so if you think about it kind of in a philosophical way, these ovarian cancers don't actually start in the ovary. the actual cells originally lived in the fallopian tube of the uterus. But we call them ovarian cancers, and we will always call them ovarian cancers. But they're just about as different as breast cancer and lung cancer. And you want to go to see a doctor and say, I'd like to see a chest oncologist, right? You'd see a breast oncologist or a lung oncologist if you're looking for a specialist. And so even though these are all treated by G1 oncologists, most of us now appreciate that they're different diseases, sometimes requiring different treatments, and certainly they have different genetic features. But Lynch syndrome is from inherited mutations in genes that affect one way that DNA can repair itself, and those mutations can lead to these cancers, and we actually do preventative surgery for women with Lynch syndrome. We don't talk about Lynch syndrome so much because BRCA1 and 2 is so much more predominant, but we probably should talk about it more in our academic and community interactions. So we pretty much talked about this. This is just a, pointing on my screen here, you can't see that. This is just a pie chart on the right side that basically shows you the frequencies of the cancers that were on the prior slide. And on the left side, I just want to make the point that for high-grade serous ovarian cancer, which we study a lot because it's predominant and very important to study, we know the frequencies of inherited BRCA mutations, but you also can have somatic BRCA mutations, which is why I made the point earlier about the difference between germline and somatic, because you also can develop mutations just within the tumor. That does not put you or your family at risk for ovarian cancer, but it can determine whether some therapy like a PARP inhibitor would be highly effective. There's other inherited mutations. So I mentioned BRCA1 and 2 and maybe a few other genes. And so now with our technology, where it used to be very difficult to sequence BRCA1 and 2 and it used to cost a lot of money, I just found out that color genomics, I don't think I get money from any of these companies, but for color genomics, you can have testing for $250 and they take no insurance. For Ambry Genetics, which we use here, the testing is $650 and they do take insurance, so most of it's covered. And then Myriad, which was the first company to do BRCA1 and 2 testing, I think is around $1,300, I'm not 100% sure. But now that we've advanced our sequencing technologies, it's just as easy now to sequence 2 genes as it is to sequence 27 genes. And because of some literature that's been published, people believe that there's genes besides BRCA1 and 2 that may increase the risk of breast and ovarian cancer, and that's true. But it's not true that there's 27 genes that increase the risk of breast and ovarian cancer. So now we have the opposite problem in some circumstances where we're testing for lots of genes and finding lots of things, and we as doctors and genetic counselors and other healthcare providers have to interpret that correctly. Because just because a report says there's a mutation or there's a variant, that does not equal this person's at high risk for ovarian cancer. We have learned a lot. We've learned that this gene here called BRIC1, and this gene here called RAD51C, and another gene called RAD51D, those are real risk genes, and they do put people at risk for ovarian cancer that is 5 to 10-fold the population risk. And so that's something we would recommend an intervention. Some of these other genes like NBN and CHEK2 and CHEK1, they don't put people at risk for ovarian cancer. Some of them, like CHEK1, no, I think it's CHEK2 actually, can increase the risk of breast cancer. PALB2 is controversial, increases the risk of breast cancer. The jury is out on ovarian cancer, probably has some small increased risk of ovarian cancer, but it's not a risk gene yet. So it's getting the sequence is getting easier, the interpretation is getting more complex. This is the traditional slide. This slide is now 15 years old, 14 years old, almost 15 years old. It just shows that BRCA1 and 2 are not the same. These numbers are slightly overinflated because the early studies have a bias towards people who are in genetic screening clinics and genetic counseling clinics and are at increased risk. But the bottom line is that BRCA1 and 2 both increase your risk of breast cancer. BRCA1 increases the risk of ovarian cancer more than BRCA2. We've also learned, as you can see in the graph, that women who have BRCA1 mutations and get ovarian cancer will do so at an earlier age than those with BRCA2 mutations, and we're confident enough in this data that we now make specific recommendations based on the actual gene that's mutated and, of course, the family history. So the recommendation is for BRCA1 carriers to undergo risk-reducing surgery by approximately age 40. And for BRCA2 carriers, we're pretty comfortable waiting until approximately age 45. And then for the new genes that I mentioned, RAD51C and D and BRIP1, we're also comfortable waiting until about age 45. Although there's less data, it does appear that those genes increase the risk, but do not necessarily make the onset much earlier, as we see in BRCA1. What else? Okay, so here are the only pretty or yucky pictures I have for you, depending how you look at it. So when we know that people are at increased risk, the most effective way, and again, whether it's dramatic or not is the personal opinion, but the most effective way to lower that risk is to remove the ovaries and fallopian tubes. That makes a lot of sense. If you're at risk for ovarian cancer, you take out the ovary, you're not going to get ovarian cancer, more or less. As we started to do that, we found cancers by accident. Those are called occult cancers, found by accident. And we find an occult cancer or a precursor cancer. So here you see on the bottom right picture here, you see this is actually normal tissue out here, and inside here, these are real cancer cells, but they haven't gone anywhere. So it's called intraepithelial carcinoma, because they're cancer cells, they haven't invaded into any underlying tissues. So those are called intraepithelial carcinomas. They frequently are found in the fallopian tube, tube, and under the microscope they have a histology that's called serous, not serious. Serous, not serious like the radio station or like the normal word, S-E-R-O-U-S, serous. And so we call these precursor lesions serous tubal intraepithelial carcinomas, which will from now on be called stick lesions, because that's a mouthful. These nice pretty pictures here show that we can do these procedures through a single incision. This is someone who had surgery. This is her belly button. It looks relatively normal because it's an incision inside the belly button, only one incision. This is what a uterus looks like, ovary, and there's a fallopian tube in there somewhere. This is probably 10 years old, so our pictures look much prettier now because we have high resolution video, etc. And once we realized that the cancers we found by accident, the occult cancers, once we realized they mostly occurred in the fallopian tube, some very smart pathologists in Boston said, well, let's look closer at the fallopian tube through a protocol called CFIM, which is serial evaluation and extensive sectioning of the end of the fallopian tube, or the fimbriated end of the fallopian tube, and that's what is shown on the other bottom left picture, just that we actually take many sections. So I'll just move that slide back for a second, but one thing most people don't know is that we take out, an ovary, which might be a normal ovary, would be about this size, and normally what happens is we split it in half and we take a look at it under the microscope with a section that's microscopic. So the thickness of the section is typically 5 microns or micrometers, which is 1,000th of a millimeter, which is this big. So it's and that's all we're looking at. So we're doing one little section, no cancer. But so they realize that if you look closer at the fallopian tube, the more you look, the more you're going to find. So now we section the fallopian tube at 1 centimeter intervals, which is still not that small. And at the end of the fallopian tube, we section it the other way. And by doing that, we found a lot of these precursor lesions. So, so that's where we came up with these occult lesions. So does that mean that these lesions cause the cancers that we see in women who get cancer? Well, how can we prove that this is true? Because this was just a theory, and I do remember 15 years ago actually criticizing, or let's say discussing the presentation of someone who first came up with this. I was like, you're crazy. And he wasn't crazy at all. Because we did lots of other studies. One in particular is we looked at mutations. So ovarian cancers have P53 mutations. P53 is a gene that's called the caretaker of the genome. It affects how cells replicate. And almost every high-grade serous carcinoma has a mutation in P53. If we don't find a mutation in P53 and we look for it, it's probably a misdiagnosed cancer and not actually high-grade serous carcinoma. So we look at the cancers and we find the specific mutation in a gene that has thousands of bases or thousands of nucleotides, and we find the same mutation at exactly the same location in a tumor as we do in the precursor lesion. That's something called clonality, and you won't see that unless the two cell populations are related to each other. So that's one way that we know. If you look at the studies I'm showing here, I know you can't read the actual tables, but you can see the numbers. 93% of the stick lesions had the same mutation in the cancer. here 5 out of 5, 12 out of 12. So there's lots of clonality, so that suggested we were on the right track. And then we looked at lots of cancers, and we found, I'll probably take questions at the end, if you don't mind. Then we looked at lots of cancers, and there'll be plenty of time for questions at the end. I'll definitely be done by 7:30, and we'll definitely have the room to 8 o'clock, and however long you want to stay. We look at the cancers, and when we look at the cancers and go back to the fallopian tube, we can find the stick lesion or the precursor lesion 50% of the time. So we're finding a lot of these precursor lesions, and that's just a couple more studies here showing that. Why we don't find them 100% of the time is a very good question. Many cases, there's so much cancer we can't identify the fallopian tube. Many cases, the precursor lesion itself might be overgrown by cancer cells. And in some cases, and this is a very important point for what I'm going to tell you later on, in some cases, the normal cells may have left the fallopian tube and turned into cancer later on. And so there is no precursor lesion to find in the fallopian tube, even though the cancer may have begun in the fallopian tube. So a couple more yucky pictures, but these are not humans. These are rodents, we call mice. And they're very important for research, and we can cure mice very well, so they're not, a perfect model. But basically, I'll show you that this is more or less a normal uterus and fallopian tubes and ovaries of a mouse. A mouse actually has what's called a bicornuate uterus. There's 2 tubes. And these investigators from Texas introduced a few mutations. You can close your eyes for a minute if you don't like the pictures. I'll be done in about a minute and a half. They introduced 2 mutations, and the mouse here got lots of cancer. Under the microscope, it looks just like human cancer. You can't tell which one of these is the mouse, which is the human, neither can I. It's no legend that I cut off. But what they did that was fascinating is they first removed the ovaries on both sides of the mouse, and the mouse still got ovarian cancer. They then removed, actually, I'm sorry, this is a normal mouse. Here's a mouse where they removed the ovaries. The mouse still got ovarian cancer. They removed one of the fallopian tubes, and the mouse got ovarian cancer on the other side, even though the ovary was still here, but there was no mouse fallopian tube, no cancer. And when they took out both fallopian tubes, the mouse got no cancer. And so and there's 3 papers like this in mouse models suggesting that the cancers are actually beginning in the fallopian tube. So this is the not so yucky picture, where basically this is showing how the cancer cells begin to grow at the end of the fallopian tube. This is the anatomy of the female genital tract, as we call it. And you can see how I was talking about. I mean, the purpose, not to simplify female anatomy, but the whole purpose of a fallopian tube is to make babies and allow the sperm and the egg to meet inside the fallopian tube right here. So once someone is done having children, the fallopian tubes serve no, reproductive biologic purpose. And the fallopian tubes here, the ovum ovulate from the ovary, of course, are picked up by these fimbria, these little finger projections, and they're taken into the fallopian tube. Fertilization occurs here. Come the premature embryo travels over here, implants into the endometrium, and then you have a baby 9 months later, or if you're not pregnant, you have a period every month. But the point is basically that this passageway, like I said, I like to say, it's connected to the outside world, and you can see how these are all spaces that normally are closed, but we can open them up very easily with painful instruments and other surgical ways to get in. So because the cancers begin in the fallopian tube, we can get there, at least theoretically. We can't get to the ovaries, so I'm not showing you a real picture here, but the ovaries inside your belly, the ovaries in your pelvis, just like your intestines, just like your appendix, just like your pancreas, more or less. We can get there, of course, with surgical procedures, but you're not going to get to an ovary in a gynecologic office. But just like a pap smear, or you can have a painful endometrial biopsy in a gynecology office, it's not a far stretch to say, instead of biopsying the endometrium, which we do a lot in the office, just to get over here into the fallopian tube, that is theoretically possible. We now have the first device that's FDA cleared and is under for investigational purposes that will probably be getting here maybe next year. We can take a small catheter and actually put it into the fallopian tube, collect some cells as if we're doing a pap smear of the fallopian tube. So that can be done. It's been done at least 20 times in California, and we're going to help them develop that technology here. It's done by a for-profit company, but it's a very good technology, and I don't know if anyone else is doing it, so we're going to try to help them develop that technology. And I don't know if it's going to be perfect. I don't know if it's going to diagnose ovarian cancers early or fallopian tube cancers, but it's at least step one to get in there. The final thing I'll tell you about this theory here is that in some of those mouse studies, which I won't show you again, in some of the mouse studies, when you actually took out the ovary, while they still got ovarian cancer, the ovarian cancer did not spread in the mouse as much as it normally would if the mouse had the ovaries. So the ovary and fallopian tube work together. So while we think that many ovarian cancers, maybe most, begin in the fallopian tube, probably not all, but many or most ovarian cancers begin in the fallopian tube, the ovary is very important. The ovary allows the cancers to grow. And when you take out the ovary, the cancers will develop, but they will not spread as quickly. So there is some relationship there. Okay, so what can we do with this information? So tubal ligation, people have their tubes tied for contraceptive purposes. In 2006, the last data I have available, which is granted 10 years ago, there were about 600,000 tubal ligations performed. It happens almost 10% of the time after someone has their last child. Evidently, 21% of married women have had a tubal ligation. And the second thing is, we're probably not saying, but we're not trying to say that every ovarian cancer begins with the fallopian tube. I think it's probably most, which means more than 50%. I would like to believe it's around 3/4, but I don't really know. I'm sure it's not 100%. It may not be 90%, but it easily could be 50%. And this easily could be 50% effective. And so taking out the tube instead of tying the tube will be effective, and we are doing that now all across the country. It's policy in some parts of Canada. Here it's strongly recommended, and most women at NYU who are having an elective tubal ligation, not right after pregnancy, but elective, most of the time the fallopian tube will be coming out. We're also taking out fallopian tubes almost all the time when someone has a hysterectomy. A hysterectomy means just the removal of the uterus. People think it means removing the ovaries, but it does not. That's called oophorectomy. But when we just take out the uterus, and obviously you can't have children if you don't have a uterus, where most of us are recommending that if we're not taking out the ovaries, which make hormones, which is why you don't want to take them out in someone who's younger or even older, because the ovaries do many things, but we are recommending taking out the fallopian tubes, because if you take out the uterus, you don't need your fallopian tubes, and they may cause cancer in the future, so that's becoming a routine practice. So we're trying to study this. So I told you this is a great theory, but it may not work perfectly, so we really have to study. We have to do two things. The first thing we have to do is make sure it's safe. So are we right in saying it's not a big deal, or are we wrong, and are we going to have surgical complications? Are we going to put women into premature menopause? There's lots of issues that we care about. So the first study we have to do, is it safe? And so we're doing that study. It's called Women Choosing Surgical Prevention. This is a study also part of the Stand Up to Cancer group, the WISP study. So the standard of care for someone who's at high risk with a BRCA1 or 2 mutation is to take out the fallopian tubes and ovaries. This is proven to reduce the risk of ovarian cancer by over 90% and to put it back to about the general population. So if we only take out the fallopian tubes and say, oh, you can keep your ovaries, we could be harming some people. We could be turning some people who have an extremely large reduction of risk and making that reduction not as great, and therefore not doing good and doing bad. So that's why we have to test this, make sure it's safe. So this is just for women who decide, I don't want to have my ovaries taken out. We know there's about 25 to 30% of women who have BRCA mutations who are recommended to have their ovaries taken out, let's say around age 40, and say, I don't want to go into menopause 10 years earlier. I don't have ovaries, so I can't agree or disagree with you, but I understand that. So that's a personal decision. So some women say, I don't want to go into menopause 10 years early. I'm just going to have ovarian cancer screening, which I'll tell you later doesn't work. And so I truly believe that taking out the fallopian tubes is probably better than screening, which I essentially say nowadays is basically doing nothing because it really doesn't work that well. So this is the study called the WISP study. It's now open at NYU, it's open at Memorial Sloan Kettering, it's open at MD Anderson, University of Washington, University of Chicago, and Dana-Farber, and it might be opening in Pittsburgh, I'm not sure. And so basically, if women are having their ovaries taken out, like many women do, we ask them to fill out some surveys, and we use that as a comparison group. And if women say, I'm not gonna have my ovaries taken out, but I'm interested in this salpingectomy, taking out the fallopian tubes, called a salpingectomy, we say, we will do that, but only in a research setting, because it's not the standard of care, and we wanna ask you some questions about the experience, we wanna follow you to make sure you don't get cancer, and that's what the study is, and it's open here, and if anyone is interested or has friends or family or acquaintances, please have them contact us. And so this study will tell us, is it safe, and does it reduce the side effects of having the ovaries taken out, which it should. The next study we were planning it for 5 years already. It probably will take at least another 5 years if it ever opens. This is a definitive study that says taking out the fallopian tubes, let's cut off a little bit. This is a definitive study that says taking out the fallopian tubes does prevent ovarian cancer. This study is going to have about 270 women on it altogether. This next study is going to have about 1,200 women. It's going to take 5 to 7 years to accrue all those people, and we're going to follow them for a total of 12 to 14 years. So it's a big endeavor. We can't just snap our fingers and do that. It's going through our cooperative group mechanism, which is called the NRG Oncology Group or the Gynecologic Oncology Group. It's been to the NCI for review. It came back for some modifications. We're trying to get it back to the NCI so they can approve it and pay for it. It probably will cost around $1 million. And so this study will say, yes, the women who had their fallopian tubes taken out had almost as much prevention as those who had their ovaries taken out. Then we know the data, and we can counsel women better and say, these are your options. 90% risk reduction if you have your ovaries taken out. Let's just say 75% risk reduction if you have your tubes taken out, and maybe 0% reduction if you just have screening. And so we hope this will be an option in the future, but it's certainly many years away before it becomes a standard of care that we can recommend. We are doing it. I do, again, just not to be too repetitive, but I do think it's better than doing nothing or having ovarian cancer screening, but it's not the standard, it's not recommended. And why do I say it's better than doing nothing? So for 20 years or more, we've tried to use the combination of ultrasonography, or called transvaginal ultrasounds, and a tumor marker called CA125. CA125 was a tumor marker discovered by Bob Bast that was designed to monitor people who had cancer. So if you have advanced cancer, it's usually very high. When your cancer goes away, it gets very low. So people said, well, can we use it to screen for cancer? Does it go up when someone's beginning to develop ovarian cancer? And the truth basically is it doesn't. So by the time it does go up, many people have advanced ovarian cancer, which we're very good at diagnosing nowadays anyway. We want to diagnose early ovarian cancer, not advanced ovarian cancer. So this study came out last year. 200,000 women in the UK enrolled in the study. And the question of any screening study is, if we do this intervention, are we saving lives? We don't want to diagnose cancer a little bit early if that early diagnosis doesn't result in saving lives, and that's what early diagnosis usually does. They had some benefit, but it didn't clearly show that it does save lives. And so as of now, the United States Preventative Services Task Force recommends against ovarian cancer screening for the average risk population. This is not BRCA1 and 2 carriers. This is the total population of women in the United States or the world, well, for the United States here. And based on this data and all the other data, we cannot say that if someone has ovarian cancer screening, there's any reassurance that ovarian cancer will be diagnosed early or prevented. That's the general population. The high-risk population, so women who have BRCA1 and 2 mutations, the jury is out. We don't have those studies done. According to the NCCN, the National Comprehensive Cancer Network, it used to be recommended. Now it's been downgraded to something to consider. So I do recommend it for my patients because it might be helpful, and I have nothing better except the surgical intervention. So for high-risk people, I recommend ovarian cancer screening, transvaginal ultrasound twice a year, CA125 measurements twice a year, admitting I have no data that it actually works, and it may not work, and it may not be better than nothing, but I don't know that yet, so I don't recommend against that. But for the appropriate person, I would recommend some other type of risk reduction, which could be surgery or non-surgery interventions. And I may forget to mention that birth control pills, like tubal ligation, do reduce the risk of ovarian cancer by 50% in anyone who takes them for 5 years or more. Whether you have a mutation or no mutation, whatever your risk is, that risk is reduced by about 50% for women who take oral contraceptives. So we need to do better. How can we do better? So we can use new technologies. That's why the technology word was thrown into the title of the word salad. So we need to do better. So circulating tumor DNA. This means, can we take those cancer cells that are inside someone's body, and cancer cells grow, but they also die. And when cancer cells die or turn over, they release DNA into the bloodstream. And we now know that we can detect that DNA in the bloodstream. So in my laboratory and several others, we're doing that. We don't know if it's going to work. We don't know if we can detect it early enough, but we're starting those studies, and we're excited about that. What else are we doing? So we're taking multiple approaches because we know that any one approach may not work. So we're also saying now, remembering the anatomic pictures, we're now putting small catheters into the uterus and putting fluid in there and taking it out called uterine washings. We have a new catheter that can do this in sort of a better way. And we did a pilot study that showed that certain tumor markers like CA-125 and others are many-fold higher in the washings of women who have cancer than those who don't. And so that's, all these studies, of course, are done with people who have established cancers that are usually and unfortunately advanced stage. And so now these studies ultimately at some point have to be moved back into a high risk or screening population. So we're just beginning these studies, but this is, you know, a potentially promising area. We published with the folks at Hopkins the fact that in a pap smear specimen, we can find those same p53 mutations that I talked about earlier. So if you take the p53 mutation that's in a cancer and you do a pap smear and you look for that same mutation, you can find it. So maybe we could use pap smears to do this. That sounds great. Is it great? It could be great. Why is it not great? Because even in women who have advanced stage cancers, we only can find that p53 mutation 40% of the time. So if you actually implemented that as a routine, you would be missing 60% of cancer. So it's very exciting we can do it 40% of the time. We thought that as time goes on, most things get better, but some data was presented at one of our meetings in the past year that even the follow-up study was actually like 37, 39%. So it hasn't gotten any better. So again, exciting technology, but not ready to be implemented, and this may not be the answer, but at least, you know, it's kind of a step of moving in the right direction. So this is another washing study that I'll skip. So what am I doing with one of my friends who's an engineer? We're taking the same idea here that all these little anatomic locations are connected. And so while we could detect, we can detect protein biomarkers here in the uterus, we would like to do this a little bit better. And we know that IUDs are effective contraception, and you can see a picture right here. And this IUD has a couple different components. It has a flexible T-shaped arms that keep the IUD in place. As you can see, it sort of matches up to a uterus theoretically, although most uteri do not look exactly like this. There are some springs, so we can take it out after 5 years or as needed. These springs are made of a monofilament type of suture material. And inside the middle of the what's called the IUD body is a cartridge. Nowadays, that cartridge typically secretes a hormone called progesterone. It secretes it continually for 5 years at a certain dose, and the combination of progesterone and physically having something in the uterus prevents pregnancies. So this is all known, but we said, well, if we can detect biomarkers in washings, what if we could design a way to detect those biomarkers on an IUD that could sit in the uterus for 5 years and could detect the biomarkers continually for 5 years or whenever we wanted to? So we know that doing a CA-125 twice a year doesn't really work. What if you could do a CA-125 every week? What if the IUD could detect CA-125 and measure it every week or every month, or measure CA-125 and another biomarker? So to do this, I ran into a guy who had just finished working at MIT, where they are very smart, and also know about engineering. And so he does nanotechnology. He works with something called carbon nanotubes. So carbon nanotubes are rings of carbon, just like diamonds and coal, but the carbon nanotubes are tubular, and they can be decorated with antibodies. And so he decorated this with an antibody that could bind CA-125 and could bind HE4. And these carbon nanotubes, when you zap them with a laser, they give off a near-infrared signal. So that's like what you would see, I guess the night vision that people have is sort of infrared. I guess that's infrared vision. So it's kind of something that can be seen if you look for it, if you have the right lasers and detectors. And what happens is when he puts these antibodies on these carbon nanotubes and then adds what's called the antigen, or the CA-125, you see a wavelength shift. And so this level down here all of a sudden goes up to here. And that's a tiny wavelength shift that a nanotechnology engineer can detect. I don't know how he does it, but he can detect it. And so basically we're using this technology now to develop an IUD device that can detect these types of antibodies. And we've done this for the past 3 years. Our first publication is circulating its way around different journals. And we've actually done this in animal models. We've put the cancer cells in the animal models, and it actually works. We kind of made our own little device because we didn't have an IUD. We took the carbon nanotubes, we put them in something called a dialysis membrane that's used for renal dialysis, but allows fluid to come in and to go out. And we put that inside the mouse who has the cancer protein and antibody. It actually works. And so we're almost ready to put this into humans. We're going to tweak it a little bit. The carbon nanotubes are proven to be safe. And basically what we're going to do is take this cartridge here that is hormone secreting, and we're going to swap it out for a gelatinous material that will hold the nanotubes. And then instead of these little strings that are suture material, we're going to develop a fiber optic that actually will replace the strings. And then instead of using a transvaginal ultrasound probe, we're going to use a transvaginal near-infrared probe, which will activate the fiber optic and measure the wavelength shift that's in the IUD. It's really cool. It sounds like science fiction. It kind of is, but we're ready to make this device. We have to make a prototype, and then the way you do new device research is you then ask 10 volunteers to have the device placed. Our first 10 people will be people who actually have ovarian cancer who are about to have an operation, because we want to make sure it works in the intended population. So someone who's about to have a hysterectomy and a surgical procedure for ovarian cancer, just before we begin the procedure while someone's asleep, we'll put this IUD device into the uterus. We'll wait about 5 minutes so it can collect some proteins. We'll then interrogate it with the probe and see that it works. Then we'll take all that stuff out into the operation and probably add about a half hour onto a multi-hour operation. So we're excited to do that. The one thing that we're mostly missing is the prototype, which has to be developed by an engineering company or a commercial company, and it will cost us $1 million to make the first prototype. So if anyone has $1 million in their back pocket, please come see me afterwards. I am actually talking to the company that made the device that puts the thing into the fallopian tube to see if their investors want to invest in this, because as you can see, it sounds pretty cool, and we think it's pretty cool too, and we hope that people with money will think it's pretty cool, and we do have patent protection and stuff like that. So we're ready to develop this. I'm sure the first iteration is not going to work perfectly, but again, we're trying new things because our old things, haven't worked very well. Just to wrap up, I just want to mention that we talked about PARP inhibitors. They work quite well in people and tumors that have a BRCA mutation, because the BRCA mutation prevents DNA to repair itself in a certain manner, and the PARP inhibitor knocks out another mechanism of repairing DNA. So putting those two things together makes the cancer cell die, which makes the person live, which is good. We have lots of PARP inhibitors that are now approved for active treatment and what's called maintenance therapy, which is preventing the cancer from coming back. These are 3 PARP inhibitors that are FDA approved for different situations. They all work best in people who have a BRCA mutation. They work second best in people who have some other measure of DNA repair deficiency. And they work to some extent in people and tumors that have intact DNA repair mechanisms, but the amount that it works is somewhat debatable and controversial. So they're approved in many settings, and we have lots of ongoing studies to test them further. As I said, they work best in women who actually have a BRCA mutation, so we're trying to figure out how to combine them to treat other people who do not have a BRCA mutation, to combine them with other drugs that will let the PARP inhibitor work in a non-BRCA mutation setting. And that leads me to my second or third to last slide. Again, at NYU, we have lots of clinical trials. We really think clinical trials are the best medical treatment for people who are in the right scenario. We have clinical trials all across the ovarian cancer continuum, from diagnosis to maintenance to recurrence, whether it's shortly after receiving platinum or a longer time after receiving platinum. Surgical treatment, of course, for recurrent cancer is also something we always consider. Most of these trials are up on our website, and so we have a very active program here. And so nowadays we can prevent ovarian cancer in most women who have an inherited BRCA1 or BRCA2 mutation. We cannot effectively screen for ovarian cancer today, and we recommend against ovarian cancer screening for women at average or population risk. We're working very hard to develop new approaches for early detection, and clinical trials are here. The WISP study is now open. Treatment for ovarian cancer is very effective. We didn't really talk about treatment today, but it is very effective and well tolerated for most women. Women with ovarian cancer can be cured, but certainly not anywhere close to the amount that we would like to cure people. And together we can improve prevention, early detection, and treatment of ovarian cancer. I'm always very grateful to partner with all of my research colleagues, my professional colleagues, and of course our patient community and other supporters, and anyone who wants to help us in our mission to improve treatments for ovarian cancer. You can see my clinical group on the left, my surgical group on the right. On top is our new hospital on 34th Street. We talked about that, all single beds, opening next summer. I'm fortunate to get research support from a number of foundations and governmental organizations. If you need to find us in our G1 Oncology Division, we developed a very easy phone number for you, 1-844-7-G1-ONC. It couldn't be any simpler. We're available to help people with whatever needs they may have. And thank you for coming tonight. If you have any questions, I will now be happy to answer them forever.
So what fraction of precursor tumors would actually pick up over time? Is the understanding, we believe that most of them will, or is it?
That's an excellent question. I think what you're asking is two things. If someone has a stick lesion sort of left untreated, will it turn into a cancer? I have no idea. And the related question is, when we do these preventative operations and we find stick lesions, what do we do? So my personal opinion, which is not one shared by most of my colleagues, is that if you have a precursor lesion, there are real cancer cells that are really exposed to the rest of the body, I recommend some form of a staging procedure where we go back to make sure those cancer cells haven't spread anywhere. The truth is we have limited data. Most of the time when we do that, we don't find that cancer cells have spread anywhere. Most of my colleagues will say that the stick lesion we don't have to treat at all, and I'll counsel my patients that most people will say you don't have to do anything else. I personally feel that we don't have enough data to know whether there's a 1 or 2% risk of cancer, a 5 or 10% risk of cancer, or a 50% risk of cancer, which I'm sure is not the case. And so I think we have to figure out what that risk is because we don't know. And I don't strongly recommend it to people, but I say, they're real cancer cells, we don't know if they can go anywhere, so we should check. And we do a limited staging procedure, and it also depends how old the person is. If they're 25 years old, 45 years old, or 65 years old, the recommendation might be different. But it's an excellent question, and we don't know the answer.
You mentioned.
I know they're doing.
One second.
You mentioned that you think maybe 75% of ovarian cancer is originated from the tubes. As we weigh these life and death decisions, what evidence is there that it does actually sometimes start in the ovary?
Oh, in the ovary? So
You mentioned some certitude that it's not just.
So we can find some cancers that are in the ovary. There's things called inclusion cysts. And the other fact is that we just don't find precursor lesions all the time in the fallopian tube. There's some basic scientific studies that suggest there's a little part of the ovary where there could be something called stem cells, and they could start in the ovary. So it's unlikely it's going to be 100%. The data would suggest it's well over 50%. But 20 years ago, we just assumed it started on the surface of the ovary, which made absolutely no sense. What we know today about the cell layer and genetic mutations and those sorts of things, we just assumed occupied the ovary had to start there. So the best available data does suggest it would be 50% or more. My estimate's like I said, 75%, but that could be off a little bit. What evidence do we have it's beginning somewhere else? Is just that we can find some of these precursor lesions or cancer on the ovary that don't involve the fallopian tube.
And you think those aren't I don't remember the term, but the sort of floating cells that might come off the fallopian tubes or
Yeah, again, that's more of a philosophical question or argument because if they once lived in the fallopian tube and now we're over here, if we took out the fallopian tube, and I do think if someone's interested in having their fallopian tubes taken out, it should be done as early as possible, meaning once someone's done having their children, if that's really what they want to do. If we took out everyone's fallopian tubes, at age 20, maybe that would have a dramatic reduction, but of course that's unrealistic. I don't think if someone's 49 and has a BRCA1 mutation, they've never had, no one's talked to them, maybe they just, didn't come into the right doctor and talked about it. At 49, to take out the fallopian tubes, to not go into menopause a year or two earlier, while that might be true, I don't think at 49 you're going to see as much of a benefit as you would at 40 because the precursor lesion could already begin or those cells could already be somewhere else. But if the idea is the cells might shed over a period of time, the earlier you were to do this in late 30s or early 40s, which is often when many people, even in New York City are done having kids.
It said that they're going to start earlier clinical studies. What are they going to try for early detection if they get it in the early stages? What are they going to try out? Are they going to try like antibiotics with and without the patients?
Right. So the study I showed from the United Kingdom and England, they did an early detection study where they tried doing ultrasound and CA-125 blood tests, and that didn't work out so well. People now are trying to do pap smear type of studies, but they're really mostly proof of principle studies to say, can we detect an early cancer? And then once you think you can detect it, then you go on to do a very large population study. I would also like to do a population study of taking out fallopian tubes, and that would be done on women at average risk. The
But if
population, the
even
study
if they
actually-
have a family history, or if they don't have a family history?
Right, so that's a good point. So you wanna, so in my own
Some
practice.
people may not have family history either.
That's right,
Some
so
do, some don't.
in my own practice, I try to categorize people as to whether someone's
Right.
at high risk for ovarian cancer or at average risk. I don't think there's a gray area. Even if the question is not known, you have to pick a bucket. Because I see people who come in who have an ultrasound once a year, and I'm like, that doesn't make any sense. I see people who come in who have like a second cousin with ovarian cancer who's having ultrasounds, you know, as if they're high risk, and I'm like, well, if you're high risk, you should consider preventative surgery. If you're not high risk, you should, you know, not worry any more than someone in the general population would worry. So I do think it's very important to either be considered high risk or be considered average risk. And even though there is gray areas where we don't know what to do, just go into one of those theoretical buckets, whether you think you're making the right decision or you're being a little too aggressive or too not aggressive.
What would you recommend for somebody who hasn't had kids that wants to have kids? Would you recommend having fallopian tubes removed as like a first step, and then the ovaries later on if this person doesn't want to go into medical menopause at 35?
How old might this person be?
Maybe 35.
So- And how quickly does the person might want to have kids? Like in the next 6 months?
Well, the person has their eggs frozen, so, so the person's just wondering, do you think it would be beneficial to have fallopian tubes removed if they weren't gonna kind of have kids the old traditional way? And
I
do
see,
you-
if someone, yeah.
could that potentially lead them to
If someone
living a longer
knew
life?
they were, you know, either infertile or was gonna need IVF anyway, and they were at high risk, like having a mutation, and they were around 35, and they weren't gonna have kids right away, and they knew that for certain they weren't gonna use their own fallopian tubes, that would be fine. I think to know that with certainty often can be difficult. Again, if someone isn't gonna have children right away, again, birth control pills are pretty good. You know, I don't know how much, again, if I'm 75% right, is 75% so much better than 50%? We are getting pretty close to 50% with birth control pills alone. If someone was gonna have children in the near future, I wouldn't go and do a surgical procedure if someone's gonna get pregnant maybe in the next 12 months. If someone say, well, I might be 35, but I, you know, just became CEO of JP Morgan, I'm not gonna have kids till I'm 42, now you're talking a 7-year period, maybe you take out the fallopian tubes and go on birth control pills just to, you know, belt and suspenders.
And the person's been on birth control for 17 years.
So they already have the maximal benefit. Even if you, so 5 years is pretty much what we say. There might be a little added benefit as you get closer to 10 years, but then once you stop the birth control pills, that benefit is there. So it doesn't go away. Once you've done 5+ years more or less, the benefit's there. I think good questions.
I'm not gonna do a hypothetical
Either way.
Doctor positive, already had breast cancer, just had bilateral mastectomy, started reconstruction. On the pill for 5 years when I was in my 20s, I'm 60 now. I have an appointment for hysterectomy, hysterectomy, whatever. And I'm just wondering what, I have a bunch of questions, but the most important really is, what are some of the side effects and what are the problems that I might be causing myself by, I mean, I understand the importance of it, obviously, or doing it. But what are some of the side effects I might expect short-term and long-term, and would other parts of my health suffer?
And
for
you're
having
curious,
had-
1 or 2?
One,
1, and you're 60.
yeah.
So can
And
you
I
just,
had my first breast cancer.
can you just educate us just out of curiosity?
Sure, anything.
Why are you finding this out now? Is it because you had no family history? You
No
got tested
family.
with your breast cancer
Right.
and found out then?
Right, yeah, so we found a tumor last October on a routine mammogram.
So you would have had no reason to have testing when you were, 10 years ago, you have no reason to have testing?
No, there was no breast cancer in my family. My cousin did have estrogen receptor, first cousin once removed had estrogen receptor breast cancer at 65.
So this.
And she's negative, so we're thinking it came from my father's side.
So you should have your ovaries and fallopian tubes removed. That's definitely a recommendation. A few things just going in your favor is since the average age of BRCA1 associated ovarian cancers is 51, and the range is easily 40 to 60, if not a little more, but you're getting towards the downside of the risk. So you definitely should have your ovaries taken. I don't want to talk you out of it, which I would not recommend, but your risk of getting ovarian cancer with your family history is probably pretty low, and the fact that you're already 60 and haven't gotten BRCA1 associated ovarian cancer is good. As far as what you should expect, the surgical procedure is pretty simple. Your doctor will probably use 3 small incisions. You feel pretty good a couple days later. I tell my people after about a week, you feel like someone punched you in the stomach. From a hormonal perspective, most people who are already in menopause, so what I've noticed from my own patients is most people don't know any difference. However, about 10% of my patients all of a sudden get hot flashes. And so what I feel, just my opinion, is that in menopause, the ovaries are doing something for some women for whatever that reason is. I don't know why. And I just had someone who was like 59 who came in. I don't know if I had done her surgery or she was talking for some reason, said, I had my ovaries taken. I was in menopause for 5 years. All of a sudden I got hot flashes. What should I do? I said, well, if they're bad enough, we can give you some medicines. So the odds are you probably won't know any difference hormonally, but there's some people who do all of a sudden get hot flashes, which is kind of.
And any other impact on any other, important things?
So between 50 and 65, there is some idea that the ovaries may give some cardioprotective effect. So when women like with early endometrial cancer who are 45, who we might otherwise take out their ovaries, we now know the ovaries can have some benefits that outweigh the cancer risk. So your ovaries, of course, have some cancer risk, so that in your case would not be beneficial. But the ovaries do probably leave, even in menopause, have some cardioprotective and other health benefits that you will slightly be losing. But if you're 60, there's pretty good studies that at 65, certainly, women who've had their ovaries taken out at 65 or over have no long-term, health problems. 50 to 65, there seems to be a slight increased risk of heart problems and maybe some other problems. So if someone's, 50 years old, maybe having a hysterectomy for fibroids or prolapse and had no good reason to have their ovaries taken out, even though they were in menopause, I would say that now 50, 52-year-old, 55-year-old should keep their ovaries. Someone who has a good reason to have their ovaries taken out, then that's a different story.
So, I should be focusing more on the rock risk than even with 5 years of having taken the pill than the cardiac risk?
Yeah, definitely, because still your lifetime risk of ovarian cancer is 40%. Even if your risk is lower, you're still probably at 10 to 15% of a very serious disease versus maybe at most a twofold increase of heart disease, which in your case, I don't know what that would be, but most people get heart disease obviously when they're quite older, and what's our average risk of heart disease? Maybe about 5%, and it goes to 8%. So definitely, and we have medicines for heart, medications for heart disease and stuff like that. I'll be here afterwards if you want some more.
Dr. Levine, thank you for what you're doing for women, and then my question is kind of simple. It's kind of related to her question, which is, do ovarian cysts have any relationship to ovarian cancer?
So normal ovarian cysts do not have any relationship to high-grade serous ovarian cancer. There's something called a borderline tumor, which is not really cancer, not really normal. Those may develop in some ovarian cysts. There are some cancers that look like cysts, and that's why we do a lot of operations for funny-looking cysts, in part because so many people are having unindicated and unnecessary sonograms, which is where the harm comes in. That's why it's recommended against, because if we screened a lot of people, we'd find a lot of funny-looking things. A lot of people would have operations out of concern, and some people would have bad things happen, like we poke the wrong thing in the wrong blood vessel. But most ovarian cysts don't turn into cancer.
Mine was 10 pounds, and it blew up, like it was like that.
So that was a mucinous ovarian tumor probably, and I just took out one that was literally the biggest one I've ever seen. It was at least, it had at least 15,000 cc's of fluid inside of it. But those are mucinous tumors, which one are rarely cancer, are usually non-cancer, and sometimes, like in my patient, was a borderline tumor, which is not cancer and not normal, but it's pretty favorable. It's almost essentially a normal tumor, and so that would not really turn into cancer, particularly not high-grade serous ovarian cancer.
Okay, thank you.
I had a sister who had ovarian, and her daughter is now hitting 40. She was told originally that when she is finished having her children to have a hysterectomy. But I'm going back, my sister was diagnosed in 1996. She is resistant to doing that. Fallopian tube removal would be a good thing for her?
Yeah, she would be, one, she should have genetic testing.
She's had genetic testing, BRCA enhanced as well.
And it's all
Yeah.
negative.
It's all negative.
You've had genetic testing?
Yes,
It's all negative.
negative, yes.
Okay. So, if there's no one else.
And we had Lynch, negative.
If there's no one else in the family with cancer, you're now a family with one person with ovarian cancer. So you have any family with someone with ovarian cancer.
My maternal aunt had some sort of reproductive cancer. She was a nun, and they would not tell us
How
what
old was
she had. She was probably in her 50s, I think.
So hard
when
to say.
she had
Hard
it.
to say. So
And her grandmother had some sort of reproductive cancer as well.
I mean, obviously,
generations.
endometrial cancer is twice as common as uterine cancer, as ovarian cancer, cervical cancer, hopefully probably not another one, not cervical cancer, but cervical cancer is also very common, particularly 50 years ago. So, you know, in the absence of, you know, so a lot of people come and say, well, my first degree relative had ovarian cancer, sister, daughter, mother, what's my risk? So the statistics suggest that anyone with one first degree relative with ovarian cancer has a twofold risk. So you're going from about 1% to about 2%. We don't recommend anything in that situation. So if you forget the family members who you don't know about, and you're a family with just one person with ovarian cancer, that's every family with someone with ovarian cancer, and particularly with negative genetic testing, that wouldn't necessarily put someone at increased risk. One question that we were discussing internally recently is if you had one family member and you had negative genetic testing, are you less than the twofold risk? Because the twofold risk comes from population studies of families with only one person with ovarian cancer. But now that we have genetic testing, you know, that twofold risk may be the one person families that actually have something like a VRCA mutation. So if you knew that the genetic test was negative, is now that family risk less than a twofold risk? And I don't know. Certainly take up the fallopian tube is reasonable. It's possible this person, you know, would be nothing. She probably should see a bona fide genetic counselor at an academic center, and they can give you some information. And it also depends on what I call, you know, people call cancer fear. You know, if someone had a relative that had a very bad situation, is, you know, really wants to avoid, obviously wants to avoid that, but you know, that person may want to undergo surgery, even if it might be unnecessary. Other people are very much afraid of surgery and would like to avoid it at all costs. And so it's not simple as just running the numbers.
I actually have 6 sisters, and we were all negative for BRCA, so her odds are very
okay. So there's 7 of you in the family, and 6 of you are negative for one person to be positive. Again, 50% risk. You could do that. It's actually probably something like 0.5 to the power of 6 or something like that. I mean, someone could calculate the chance that this person has a mutation. These 6 people. I think my daughter could probably do that. But so I would.
She did it. The genetic counselor did it. Yeah.
So then I would put you in the average risk bucket.
Okay.
And then you're at average risk. But yes, my sister had ovarian cancer. Well, I have a 1% risk. Am I, you know, is that high enough for me because of my family member?
Well, I'm thinking of her daughter.
Well, so her daughter's the same risk as you because you're both first
Okay.
relatives.
Okay.
So whatever your risk is, so now you know the risk of this person having a mutation, the daughter's risk is half of that. And we just decided that 0.5 to the power of 6 is a small number. So it's very small, probably not much more than the population risk of 1 or 1.5%.
Okay.
Any connection with having a hysterectomy around age 40 and a shorter life expectancy?
Yes, so that's where I was saying taking out the ovaries, 50 to 65 or 40 to 50, there are some increased risks of what's called all-cause mortality, which often is attributed also to lung cancer, which is kind of weird. Why would we take out the ovaries if you're lung cancer? I don't know. And some heart disease. And so, yeah, so there's a statistically shorter life expectancy. But if you had your ovaries taken out for a good reason, like a BRCA mutation, where you have a 40% chance of having ovarian cancer, that statistical increase of heart disease is probably much less than the statistical increase of getting and unfortunately dying of ovarian cancer. So that's why we're very comfortable recommending someone who's 40 with a BRCA1 mutation should have their ovaries taken out because we're dramatically reducing their all-cause mortality. We know that. But if someone's having a hysterectomy for simple purposes like fibroids and you're 40, no way should their ovaries taken out because that would be detrimental. So it's all a balance of risks and benefits and sort of competing risks.
You said BRCA1. What about 2?
BRCA2 is about a lifetime risk of 20%. And again, if you take out your ovaries at 45, the increase of all-cause mortality is probably not as much as 40. Don't forget, take out the ovaries early also prevents breast cancer by 50%. So there's lots of competing. It also may prevent, I think, colorectal cancer. So while yes, all-cause mortality does go up statistically, you have to think of absolute numbers. So again, the endometriosis increases the risk by 2-fold, just like having a family member. That's pretty low. So going from a 1% risk to a 2% risk is pretty low. The risk of breast cancer in most women is around 9 or 10% of lifetime. Going to 11% is a 10% increase, but it's 1%. That might be a lot for somebody. Across the population, that's going to be an extra 20,000 cases, but for an individual, is that 1% risk worth doing something? So even for BRCA2, you're talking a 20% risk of a very serious cancer. It could be serious, but also serious. And now you're going to reduce that by 90% compared to, let's say, breast cancer, where admittedly the screening is better. We have mammography, we have MRIs. They work pretty well. I can't give you the numbers because I don't do that sort of thing, but we know ovarian cancer screening doesn't work. So even for someone with BRCA2, we're happy now going from 40 to about 45 unless someone has a very strong family history of early onset, but they're always competing risks. And it's pretty clear in the BRCA2 carrier, the risk of ovarian cancer is much greater than the risk of having, dying from heart disease or something.